My name is Dr. Ramy Khalil. I am an internal medicine physician, consultant in internal medicine, and I also have experience in healthcare IT and currently serve as the medical director for clinical informatics at PeopleOne Health, which is a US-based direct primary care organization. It's really a privilege to be on stage here with such talented individuals, and I'd like to give everyone the opportunity to introduce themselves. Before we do, just a focus on the topic for the discussion today. Really, the common theme is that there is recognition that traditional healthcare delivery models can be inadequate in today's healthcare space with the needs that have evolved in the post-pandemic era. And everybody on this stage has an idea or a passion for what they feel would be ripe for care model delivery redesign. So why don't we go down and everyone can introduce themselves, their background, their area of expertise, and if they could answer the question, what in your experience is an area of healthcare that would be amenable to an alternative care delivery model? We'll start with Professor Andrew.
Hi, I'm Andrew Wardley. I'm the co-founder and chief executive of Outreach Research Innovation Group. I'm a medical oncologist by training. I've spent 20 years involved in devising clinical trials, delivering clinical trials, partnering with many other people in teams to deliver clinical trials, but also implementing those into service design to make treatments equitable and efficient across populations. I did most of that work within the NHS for 20 years. I found that within the NHS, fragmentation and silo working was preventing patients having access to the best care. Hence, I set up Outreach Research Innovation Group to enable better access to new treatments for patients. And we are achieving that in the northwest of England. So I think the biggest challenges that we face are the lack of workforce, the rapidly developing knowledge base that we all have to contend with, and being able to deliver that equally to patients across the population with different intelligence levels, different abilities to travel around the country that they live in to access care. And we need to be able to enable them to get the care that they need and to deliver it to them rather than making them come to us.
Good morning. My name is David Golding. Thank you, Ramy. And welcome, everybody. I've had a very diverse background. I've had 5 separate careers. I started as a nuclear physicist and then became a software engineer working for the British military, writing software systems for air-to-air missiles and nuclear missiles. I moved into banking as a project manager and then pharmaceuticals. So I ran extremely large programs of change in regulated environments. Around 2007, I started my own company, which became incredibly successful. And over the next 10 years, we turned over $2 billion. And that gave me great wealth. And the fantastic thing about money is it gives you choices. The trouble was at that time, I did not make good choices. I became an alcoholic and a cocaine addict and a gambling addict, and I completely exploded my own life and nearly died. I got into recovery, and that's what I do now. The particular thing that I'm interested in is about lived experience. So I work with alcoholics and cocaine addicts and gambling addicts within an LERO, a lived experience recovery organization. So my particular focus is in the person-centered model of how we care for individuals, specifically with people with lived experience. Thank you.
Good morning. My name is Dr. Sarfraz. Well, I've been a clinician around 10 years ago, shifted into the business of medicine from the practice of medicine. And I guess when you look at alternative care delivery models, I think I will divide the whole ecosystem of the delivery of healthcare in 2. One was pre-COVID and one is post-COVID. Now, I think COVID has definitely been an enabler, if I may use that word, to the alternative care delivery models. If you look at telehealth, you look at home health, you look at the wearable devices, I think the congregation of technology, the congregation of intent, and the acceptability is what has coined the term alternative care delivery model. And yes, we were introduced, the topic was introduced, optimization of the cost is going to be an important parameter here. And even the preventive healthcare. Generally, when you look at healthcare in the conservative sense, the focus wasn't so much on the preventive component. But with your alternative care delivery models, there's a lot of focus on the preventive component of healthcare, which in turn will lead to optimization of healthcare, which in turn will lead to having a better control on the cost of healthcare, which I'm sure we'll discuss in the as the discussion follows.
Thank you, everyone, for sharing. I'll touch briefly on an area that is near and dear to me, which is the cost of health insurance. So as a physician, most of my patients are insured and they have health insurance and provided to them by their employer. Employer-sponsored healthcare is very common in the United States. More than 60% of individuals have health insurance from their employer. Also very common here in Dubai and as well as in Abu Dhabi and in Ain, where it's mandated that employers provide health insurance. Unfortunately, health insurance has become increasingly expensive. Year after year, employers are finding it difficult to pay for health insurance for their employees. And it's nearly impossible for a small employer to provide health insurance to their employees. From a patient perspective, patients are paying more premiums to their employers for healthcare, and also more out-of-pocket expense year after year. So much so that they're rationing care. They don't go to the doctor because it's too expensive. These are insured individuals. In some families I've taken care of, their expenses are so high that it surpasses what they have in the bank. We call these people functionally uninsured. So fortunately, there's been a recognition of this problem in the United States, and essentially there's an understanding that the insurance model perhaps does not work for provision of primary care. What a lot of employers are now turning to is called direct primary care, which is a membership-based model where care is delivered without an insurer, without a third-party payer, and at a fixed rate. So when when an employer engages with a DPC or direct primary care group, they will pay a per employee per month rate to provide comprehensive care to their employee. This is all visits, all telehealth, a number of medications, all labs, diagnostics, essentially all preventative healthcare and chronic disease management, which is really 80 to 90% of healthcare delivered for a capitated rate. And what we found is when we deliver this care delivery model, everybody wins, everyone's happy. The providers are happy because they're no longer inhibited with day-to-day administrative tasks imposed by insurers. They can practice medicine the way they see fit, and they can provide meaningful care to their patients. Patients are happier because they have much longer visits with their care provider, essentially unlimited access, and they have no out-of-pocket expense, no deductible, no co-insurance. And most important, I think for a business case perspective, employers are happy because it's a cost-effective model. Employers are now able to provide a premium product to their employees at a fraction of the cost, where previously they were unable to afford it. Their employee workforce is healthier, happier. They spend less time away from work. So I'm excited about direct primary care. Obviously, I work in the space. I'm excited to see it flourish in the US, and I'm excited to see it flourish here. So with that, I think we can start some discussion. I think when we think about alternative care delivery, the first thing that we think about is telehealth. Telehealth was once considered a loss leader in the industry, and in the post-pandemic era, it has really emerged as a viable means to deliver care. So where has telehealth succeeded in the past 5 years, and where has it fallen short?
Well, I think if you look at telehealth, what comes to mind is the ease of accessing healthcare. That would be one of the primary, deliverables of telehealth. Even the compliance. So I think compliance to the regime. If you look at the insurance cost, that was a very valid point you mentioned. If you look at insurance cost, one of the major causes of insurance cost is hospitalization, IP care. So if you look at telehealth as a tool, not only from the primary sense of the word, to deliver the primary health, but also to act as a compliance. What if there is a diabetic patient or a hypertensive patient? And this is I mean, in study as I talk. So what if there are two categories of patients, and these patients would land up, if they don't have, they would land up for an IP admission if they do not have compliance to the medications, if they don't have compliance to the investigations required periodically to make sure that yes, the glucose or the blood pressure or the other, the blood works are in norms. So telehealth could be a point wherein you have a scheduled call, and I think telehealth works a lot in supplement or in complement with, I'm using the term home health for reasons I will explain. So you have a patient who is supposed to follow up with the doctor, let's say in 2 weeks. For multiple reasons, not getting into the details, a patient forgets to follow up with the doctor. With telehealth, you can ensure compliance to the follow-ups. Now, if I supplement telehealth with, let's say, home health, I can make sure that if that patient is to follow up for blood works, whatever reasons, not able to go to the medical provider, if I can have a clinician talk to him, if I can have a healthcare worker take the basic blood works or the basic samples needed, I can make sure that any deviations from the norm expected by the clinician is addressed promptly. That will lead to a decrease in the number of complications. That will lead to a decrease in your IP, hospitalizations, which again would manifest as a benefit towards the cost optimization for the insurance, which you clearly mentioned. The second part, I think, the crux of telehealth would be accessibility of healthcare. Now, just recently, I think it was last year, we had the Arab Health Conference, and the number of products which have come out. There was one product I categorically remember, and it was, it was coined "doctor in a bag." So I was very surprised. I said, "Doctor in a bag, what is this?" So basically, it was all wearable devices with AI, enabled, functionality. And now, in the Middle East, for example, if you look at one of the major components of revenue, it's oil and gas. Oil and gas fields are in remote locations. So the whole concept was, let's have wearables which can be, which could be, let's say, managed by a medical worker, not a clinician, by a normal medical worker who could be trained towards the use of the wearable devices. And you could use them at any oil rig. You can use them at any remote location. Now, that, along with telehealth, is a solution for remote health. So I think the discussion can go on and on, but I guess telehealth is not just in the primitive stage that we were looking at, let's say in the COVID era, but I think it's increased exponentially in the last, I'll say, 1.5 to 2 years.
Ramy, I'd like to say, look, I want to be the 13th man here today. Okay, I'm not a clinician. I'm on the other side, but just picking up on telehealth, and I don't want to take a broad brush approach to everything. But I'm going to speak in the language that I understood for 30 years, which is for any project, any initiative, we've got really 3 variables. We fix the scope, and then we've got time, cost, and quality. Okay, which ones do you want? So if we're starting an initiative to save time, or to do it at a reduced cost, and typically I think initiatives begin like that. They come up with a scope to say, we want greater access, so therefore we'll save time and we'll save money. And I'm always concerned about the quality, and I'm concerned about the human interaction, the humanity of what we do. And I think that much of healthcare is about individuals talking. There's so many instances where loneliness is pervasive, and we find that for some people in our society, meeting a GP personally might be their only human interaction. And they might come across and appear to be hypochondriacs, but actually they want to see somebody. And I think that things like telehealth, whilst they're excellent in achieving certain objectives, I want to make sure that we never lose sight of the fact that human beings need human beings. So whilst I'll give it a big tick, I'll also say there's a huge concern that the further we go, the further that we go to isolate people at home and not have human interaction, I think the worse society might get.
So I totally agree with David. We can't move into a single bucket to deliver treatment by one model. We have to have different ways to deal with different patients, but also different ways to deal with the same patient at different points in their journey. For instance, in cancer medicine, it's very important that you see the patient at your first visit in person if you can. If you can't, then a remote consultation is better than nothing, and we do have better ways of doing remote consultation now than we did in the past. Once you've set a treatment plan for the patient, then you don't necessarily need to bring them all the way to hospital every time they need a consultation. These are patients often suffering a huge burden of cancer-related symptoms. And on top of that, you've imposed a lot of treatment-related symptom burden. And then you're going to drag them, 5 miles, 10 miles, 20 miles, 50 miles across the country to see you for a 10-minute consultation. And actually, they're going to then get their drugs delivered to them by a courier. They're not needed to be on the site. We've got better ways of delivering treatments to patients. I spent a lot of my time in my career trying to move treatment away from the hospital towards the patient so that they did not have to endure these very uncomfortable journeys, long waits in hospital for a 10-minute consultation with a consultant to say, oh, you're fine, get on with your treatment, because that was often what they got. So we need flexibility. We need the patient to be able to speak to the doctor or doctor's team at the appropriate time, and often telemedicine can be very efficient in doing that. That's the delivery of treatment part. There's also what happens to the patients after, if they get a serious complication of treatment. I saw a fantastic presentation last year at the UK Oncology Forum by a team in London who were able to go out and assess and treat patients with quite major issues in their home and avoid them getting to hospital. We see that this happens a lot in those big truck-shaped ambulances. That's where the main bit of care happens for patients with very serious conditions. Unless you're stabilised on site, you will not get to hospital alive. And actually, a lot of the extra care can actually be moved out to the patient, and the technology is really enabled for that. So I think those are the things that we have been able to see in the last few years, driven partly by the COVID pandemic, forcing that on us. But that forced change, I think, has given us some benefits that we do need to think about healthcare systems in a better way. And also systems like the Merseyside system, where they have a complete virtual ward of all their cancer patients who are in acute oncology situation, and they keep them monitored, and they're able to send out teams as appropriate to deal with their care on site, in the home, if they can do, but then to move them to hospital if needed. And we know that, as David said, a lot of the expense, and also Sarfraz said, a lot of the expense of cancer care is that period in hospital, and it a lot of the time it's not necessary, either for the patient or for the hospital, and getting patients out is very difficult once they're in there. So I think those things are moving us forward, but we need to keep developing those teams that can work together efficiently. Thank you.
Excellent points. I think we've touched upon this a bit, but let's take it to the other end of the spectrum. I think with telehealth, we can reach a number of people we otherwise would not have been able to. What about in-home care? Is in-home care something that can be viable in today's healthcare system? In what way can it be viable? And should it matter that in-home care is essentially not something that can scale easily? And actually, David, if you wouldn't mind taking this question.
Okay, bless you. Gosh, well, look, I'm going to look at this from what's the perfect scenario for humanity? Okay, people with people, this lived experience as well as care in the home. It just achieves so many things. It ticks so many boxes. But look, and I'm not a fool. The cost of that must be paid for. And it's very interesting, I come from the UK, and we've got the NHS, which has got its own funding issues. And then when you move into a model of insurance, and as you were saying, Ramy, at the beginning, about care that's preventative, very difficult. So I can only imagine how difficult it is to try and construct a mechanism that achieves the objectives of doing wonderful things for individuals, making it easier, making it quick, and getting people in front of the right people at the right time. But then the seesaw moment of that is the absolute cost of doing these things. And when the cost of these things are borne by private organizations that want to make a profit, there's a whole conundrum there, which I will be absolutely honest, I don't know how to square that circle. I really don't.
Can I jump in there? So I did set up services to deliver cancer treatments to patients' home back in 2005. Interestingly, in the UK, we have the VAT loophole, which enables VAT to be exempt from drugs if they're delivered to the patient home and not to a hospital. So that does enable in the UK for patients to have access to home care. And by necessity, we were forced down this route, and I developed a model of care across the Greater Manchester system in 2005 to deliver adjuvant Herceptin, because we just did not have capacity within the hospital to bring patients for what was then an hour and a half initial infusion with a 6-hour wait in the chair afterwards, and then subsequent infusion times of an hour and a half an hour with reduced observation times. And we eventually spun that out as a company from the NHS to be able to do that work after a few years. I've also developed care systems to deliver treatments in GP surgeries, which is a little bit more efficient because you can achieve more patient visits in one setting than you can in an individual patient's home. There is a challenge, however, because not every patient wants treatment in their home for various reasons. They sometimes don't want their home to become hospitalised. They don't want the associations of their treatment to be in their home, whereas other patients really like it, or they like to be treated at a location close to where they're working for obvious reasons. There's the other side of the coin as well. As David said earlier, sometimes patients want to come every week to the hospital to have their weekly paclitaxel because they meet their colleagues that are being treated with the same treatments and they can socialise in that environment. So I think, again, we have to think about what suits the individuals and what is manageable and what can you deliver, and not go down a one-size-fits-all model. I think we do really have to start trying to personalise care as much as possible, and that's going to be variable for different people. Thank you.
Thank you. I'll just also comment on hospice care, which I think in many cases can be delivered in home so that patients at the end of their life can die with dignity next to their families. Hospice care is quite strongly funded in the United States, although I'm not entirely sure how well funded it is in other healthcare markets. Is hospice care something that is recognized in-home hospice care in the UK?
So there is in-home care for patients. It's usually a team approach between the hospices in the UK, which are mainly charitably funded, but collaboration between the teams within the hospices, Macmillan nurses, well, not Macmillan, that's one of the charities, there may be other charity funded. So nurses funded by charity who can go out to help support the patients in their homes, but also linking with the primary care physicians who are often excellent at doing the palliative care and have their own team. So it's a team approach, linking in as appropriate with the cancer centre if need be, if they're still on active treatment. So yes, we have a mixed model that works variably in different parts of the country.
Let's pivot and talk a bit about AI. I want to be the first person to ask about AI today. It wouldn't be a complete panel if we didn't talk about AI. We're in an AI gold rush, and I want to ask my colleagues, what roles do you think AI or other tech innovations can play in alternative care delivery?
So there was a model which I clearly remember we were working on. So it was based on a couple of aggregators. This was, again, primarily based on wearable devices. And the sample was elderly. the whole idea was that, specifically in the Middle East, so you have got, for expats in the Middle East, you've got your parents staying back home, in your respective countries, and you're in the Middle East. How do you make sure that they're optimally taken care of? So the model was, we have, not just a model, it's in the final stages of revenue discussions. So you have a wearable, and based on the disease pattern that you have, the data capture is based on the disease pattern. For example, if you're diabetic, or if you've had stroke, or you're hypertensive, or you've got some cardiac ailment, the data capture will be based on what has been the diagnosis. This data would be transmitted to a group of clinicians. And again, the aggregator over here was, we tried to peg it to clinicians nearest you. So in case there's a variation from, from the norm that is expected, the clinician nearest you would be pegged, would be tagged. The nearest emergency care facility would be tagged. And the nearest ambulance would be tagged. The whole idea was to make sure that you have immediate care, you have timely care, and you have all the components of care. So you don't need a clinician to come and have a look at you. At the same time, if needed, the emergency department of the hospital knows you're available, knows that you would be coming. The nearest ambulance is already tagged and waiting for the physician's go-ahead to come and, to come at your doorstep. Beyond this, there was also a upscaling of the data to the, in this case, it was to the person who was subscribed to the model. So the whole idea here was, how do we look at preventive care? And this was just a part of it. Using AI to understand the disease pattern in individuals who are susceptible to, let's say, to a complication. For example, if you have just had a cardiac event, you are susceptible to a couple of complications. So how do we go ahead and using variables? And again, I would use the word alternative care delivery models. How do we club these two and ensure that with AI and even machine learning, we are able to have a very personalized model of care? And there were a lot of revenue models that we were talking about, towards a subscription-based model, towards a hospital-based model. The hospitals could provide this for the patients. The children could go ahead and subscribe to this model for their parents, and even for some insurance providers who could actually look at this for a particular cohort, wherein they are scared about complications. So yes, I think there is a lot of there's a lot of work which needs to be done. I'm just telling you something which has been in discussion. But yes, AI, machine learning, and wearables, I think that these three would change the landscape.
25 years ago, actually, I had a company that was using neural networks to make predictions. And the software that I worked with ended up in Amazon, and it made the recommendations. So if you go and buy a book, and it'll recommend you another book, it's because Professor Andrews bought 6, and I bought 7. So it says, oh, these guys are the same. So look, that was the genesis of my dipping my toe into AI. Gosh, things have changed. And I think what's going on at the moment with AI is a whole heap of fear. And I think the term AI seems to encapsulate an Excel spreadsheet that runs a macro. People are calling that, I've got AI in my company. And then, obviously, extremely good business and extremely good big data applications. A good friend of mine that I went to university with, Professor Holmes from Oxford University, is using AI to look at genomics. And he's the chair of the Turing Foundation. So, fantastic applications of AI to look at data and to do wonderful things. I think the fear is that we're going to have a therapist in an app. And I can tell you those are being built already. We don't need clinical psychologists. I've got this lovely app called Brian. And I say, hi, Brian, I'm feeling suicidal. And Brian says, don't worry about that. Go for a swim. And I'm taking the mickey because I fear that that's what's going to happen. That's where we're going to go. And I think with generative AI, I think the next versions of AI, they're accelerating incredibly fast. And I think that what I can anticipate is that the next evolution in AI will invent the next AI, and things will run away with itself. But I think that AI seems to encapsulate at the moment any sort of computer tech. And people want to buy a .ai domain to make it sound like they're a tech company and can be a unicorn. So whilst I think it's fantastic, again, I'm going to be the 13th man. very scary for what people might choose to do with it. It's not a panacea to fix everything.
Yeah, so obviously I don't want to be the first warrior fighting the Terminator, but I'll be there if I have to be. But I think AI has huge potential for us. I think we've seen how AI-aided radiology can improve diagnostic ability for radiologists, but working for the radiologist, not instead of. And again, we're seeing developments in AI-assisted pathology, so to enable pathologists to be able to do their work more efficiently. Having spent a lot of time trying to develop new drugs for cancer patients and done that quite effectively, I was quite involved in developing a tool to try and identify patients who would be eligible for certain clinical trials at their next progression. And we can see that actually oncology is probably one of the specialties that most aligns itself to an algorithmic approach. And I think it could be used effectively to make treatments more efficient, to aid, getting those doctors who spend the whole afternoon in an MDT looking at their phone, wondering what the football scores are or the cricket scores, depending what the season is, and actually get them back to facing the patients and imparting the right information to the patients. Because I see such variation in practice, even though there's only one evidence base for treatment, and you could actually use AI to more efficiently structure time for doctors to actually say, well, I've ticked these boxes, therefore this fits this algorithm, we recommend this pathway. And we've talked about that, the excessive time that doctors and other clinicians spend in an MDT and trying to get them back to the workforce. And there was a piece of work done by Martin Gore before he sadly died to try and streamline MDTs, and AI would lend itself to that, and I think it could make healthcare much more efficient. It won't take away the human interaction. I don't think we're at a point where AI can replace the empathy and the sympathy that you get from an individual. That is a very human thing, and we are still the most efficient computers in the world individually and collectively.
Thank you. I think what I'm hearing is AI can enable us, but it should not displace us. And David, as you said, it should not be it's not the panacea of healthcare redesign. I think claims that it could be, I think need to be met with a healthy dose of skepticism. Let's talk about dollars and cents. How can alternative care delivery contribute to cost savings for patients and healthcare organizations, in your estimation?
Well, let me put it this way. If you look at the number of hospital beds, specialty, vis-a-vis the population which is to be served, and I'm not pegging it to private healthcare or public healthcare specifically. I'm just being very general about it. So there is a huge waiting time. Let's talk surgeries. There is a waiting time for your surgeries, routine surgeries, not even getting into the complex surgeries. One way where, for example, the home care model works is, could we discharge the patient faster? I mean, a normal stay in a hospital is, let's say, 3 days post-surgery. Could we discharge the patient within 24 hours if the patient is stable and do all the other follow-ups at home? That way, the availability of your hospital beds is definitely going to get better. So one is you have got a benefit in your cost because the continuum of care is at home. Again, I'm not getting into the medical specifics. This is on a case-to-case basis. At the same time, it also helps on your revenue, because if you can churn out more cases, it's a revenue contributor. The second parameter is if you actually go ahead and look at long stay care. Long stay care, specifically in the Middle East, is something which is you've got block beds for whatever reasons. That is an area where I think with home care you can have more personalized modalities of care. There is ease of care, as well as you're easing up the bottlenecks when it comes to the hospitals where there is a waiting list for the patients. So I think that's one model. Beyond that, again, like I said, if you look at ensuring compliance to treatment, if you look at various modes and models, which are, as we speak, in discussion of final stages, how do you look at decreasing your hospital stays? I mean, so those are two major areas, I think, Beyond, obviously, if you have telehealth, the cost of operations goes down because you don't have physical queues, you don't have, you don't really need so many manpower to service the same number of patients as you would if they were physically coming to your premises. So yes, I mean, there are benefits for sure.
I'd like to take this opportunity to talk about lived experience recovery organisations. That's my area of particular interest at the moment. If we imagine addiction and the impact on society of addiction, the implicit cost on society of addiction is just colossal. And I know that in the UK, I can only speak really for the UK at the moment, which is the recent government white paper talks about utilising lived experience recovery organisations. And I think that they're really beginning to see the impact of these. So let's just explain for those that don't know. I'm a 12-step advocate. I mean, I found recovery in the rooms of Alcoholics Anonymous and Cocaine Anonymous, Gamblers Anonymous. You know, and what we have there is a system that's been working for 85 years. People literally walk off the street, go into an AA meeting and become sober. Now, I think the governments are beginning to realise that that's a fantastic model. You know, it doesn't cost them anything, but actually if it works, the impact, the positive impact on the finances of the nation is also positive. And that's what myself and my business partner, Dr. David Lee, we're trying to create here in the UAE, a day hub. We're trying to create something here which is a lived experience recovery organisation. It doesn't exist here. We clearly have rehabs here, but there's a very idiosyncratic problem here. So I think that what I want to say is whether it's addiction and recovery or whether it's patients that come together and learn from each other's experiences, whether it's in cancer or other mental health situations, for me, the cost-benefit analysis of individuals with lived experience holding the hands of other people is just colossal. And if anyone wants to come and support me and my business partner in creating a day hub, we would welcome any contributions, financial or otherwise.
So yes, I think the work you're doing is absolutely fantastic. It's what we might call in a oncology parlance secondary prevention, stopping those second events that take up a huge amount of time in hospital. I remember going back to when I was a registrar in general medicine. We had this lovely chap who was an alcoholic with liver failure, and he just kept coming in every week or 2 weeks. You could expect it, and you had to roll him around as fast as possible. He was a lovely guy, but if there was a system to keep him out of hospital, it would have saved a huge amount of money. And I think those are the things that we really need to think about. And perhaps more so than that, we need to start trying to think about primary prevention and actually stopping illnesses in the first place. But that isn't the reason that we're discussing this here. But maybe taxing sugar would be a good way forward. That's my personal opinion. So, as Sarfraz mentioned, the main issue is that time in hospital. It's hugely expensive, and a lot of that is actually just hotel cost. It's not actually the cost of treating and looking after the person who needs care. And we need to make sure that we have systems where commissioning goes with care activity, not episodes in hospital. And that is sometimes quite challenging. It has been challenging within the UK in certain ways of delivering healthcare. So delivering cancer treatments out of hospital was quite a challenge until we made sure that we got paid the right amount for the treatment delivery as we would have got for that patient coming to hospital. So we need to remove the false incentives to bring patients into certain facilities, because that activity, the money follows that activity. That needs to be stopped, and that, I think, is the biggest challenge that we face in a lot of healthcare systems.
I think that the question, who's going to pay for it, is often the question where a lot of these discussions about innovation, they go to die, basically. So, but my response to that is, taking care of patients can be incredibly cheap. It's the other stuff that's expensive. Insuring them is incredibly expensive. So emphasis on upstream prevention can have remarkable downstream cost savings. We have some more questions, but I think in the interest of time, we'd like to open it for questions. So thank you everyone for your thoughts, and we can open it up for questions from the audience.
The microphone is just in the center of the room here, please. Thank you.
Hi, good morning. I'm Dr. Kenny. So thank you for the panelists. A very simple question. Looking into alternative development and also virtual consultation, that advantage will be on human touch, as what Mr. David said. We will look into the possibility of this virtual reality in combination with virtual consultation, creating a synergistic effect to go against the disadvantage of human touch. What is your perception towards this direction? Thank you.
Yeah, I'd like to just mention that. Virtual reality, look, it's fantastic. My daughter, who's 12, got an Oculus for Christmas, and I played on it, and it's so good. I get dizzy and nearly fall over and feel like vomiting. I think it's another opportunity where we can get in front of people and we can speak to people. It's going to be better than a Zoom call, I think. I think it's marvelous. But again, I fear what's happening is the disconnect with human beings. I'll give you an example. Over COVID, people began working at home. There's a whole movement now where companies want you to work from home. And in fact, people who were going for job interviews saying, if I can't work from home, I'm not going to work for you. And I've seen that on LinkedIn. And offices are becoming emptier and emptier. Now, overall, if you look at the statistics, the overall happiness of workers has gone up. Okay, so as a graph, 90% of people say, I love working at home. I've got more free time. I don't need to travel to and from work. I save 3 hours a day commuting. And isn't life much, much better? 10% of people are really struggling, because they are now entirely isolated. They don't go into work. They don't see other human beings. They don't get any oxytocin, and they're extremely lonely. And I think that the statistics don't show up that real truth. And I think VR is another fantastic opportunity for us to do different things, but I just don't want it to be at the expense of humanity.
So I think that's a very valid point, what Mr. David has made. But when you look at healthcare, there is a cost. When you look at specializations, when you look at super specializations, there is a cost. If you look at virtual reality and you look at teleconsultation, that cost comes down. So I think the assess the cost and the value proposition, I mean, that is one mode. So I think, yes, that would be, if you want to be assessed, if you want specialized opinions to be accessible, then yes, this combination is going to be the way ahead. But I absolutely agree with the human touch.
So obviously we have a very limited workforce, and we need to educate a much greater workforce to be able to deliver the treatments that are coming. And I see a huge potential advantage for virtual reality to be able to educate people, to be able to deliver standardized education across systems rather than having it very fragmented, because the skills we need to learn are pretty much the same if you're in a particular speciality. And I think that could quite well be standardized and put into a virtual reality for people to experience a surgical procedure, for instance, that they need to learn, an acute medicine situation that they need to be able to deal with if they're in a medical scenario. So I see that probably as the first point where virtual reality might be really advantageous to training people.
I think we have time for maybe one or two more.
Hi, I'm Dr. David Lee. I'm a consultant clinical psychologist, certified recovery coach, and David Golding's business partner as well. I'd just like to pick up on some of the things that were talked about there, and what David talked about in terms of lived experience. And I'd just be really interested in the panel's view more generally on this. If we are valuing lived experience and, in our approach to healthcare and treatment, how do we merge that with our existing medical model, if you like, which is very much an expert-based model around, symptoms and diagnosis? How do we integrate those two? What is the room for the integration of the two? And the second point, what I'd like to add to that, is what are the implications that might have towards our movement towards integrating physical healthcare with mental healthcare? you know, there's been, in recent years, a move towards considering the two as, you know, not mutually exclusive, but reciprocal. Just like your thoughts on that.
So you're talking about the connection between the mind and the body, are you?
Connection between the mind and the body, yeah, and the implications that, for example, if we move towards valuing lived experience in medical treatment and healthcare generally, what are the implications that might have for physical health and mental health care together?
So I totally believe in the connection between the mind and the body. I think there's a huge wealth of data that supports that, and we know that patients or people that give up, and they die quickly, whereas people who want to benefit are much more likely to survive for longer. We also know that the challenges of a workplace environment are increasing as technologies increase, as demands increase, and that is also something that we need to bear in mind going forwards. And David alluded to it, the differences between people need to be considered. Different people have different needs. So I'm neurodivergent. I've only just found that out because it didn't exist when I was a child. I was just thought to be odd and difficult and, you know, not talkative and a bit thick, unfortunately. So some of my teachers just brushed me aside because I didn't play the game the way they expected me to. And I had to do a lot of self-learning, and I've become quite independent. So I think there are people that have different needs, and I think I've tried to express that. And we need to try and accommodate people's different needs by not having a single system. And we need to take care of people's mental health. We saw that the pandemic was devastating to the majority of people's mental health. And I, as well, experienced that. I was forced to work at home doing back-to-back meetings with no gaps in between, and that was impossible. No human being is a machine. We do need to consider our human needs, and they vary between different people. As long as we consider the differences between people and make as many accommodations to enable everyone to be happy, I think that's how we'll get to a better place in the world.
Thank you for the insightful questions. Thank you to my peers for their perspectives. This was a lovely discussion.
Can I ask the last question?
I'm sorry.
Thank you very much, panelists. Sorry we're all out of time, but please put your hands together for the incredible discussion. Sorry?
Right. So I'm Nanda from MedAvatar. When you spoke about AI, right? So we are already having a system with a complete AI model. So when you talk about the data privacy, we have a vast amount of data we are accessing. So is there any regulation that you already have in US and UK to be in place? Because when you talk about everything, right, we have a prescriptions on the dosage level, and we are creating a personalized healthcare program for each and every individual. So what kind of data privacy we are looking at, or what kind of regulations that you're looking for putting on AI in healthcare?
I'm sorry, can you say it one more time? I didn't catch the question. Okay, can you step a little closer to the microphone and just ask the question once more? I'm so sorry.
Is it audible now? Clear?
Yeah.
Right. So when you talk about AI, right, we already have an AI system in our place. So we are trying to create a personalized healthcare program for each and every individual. So we have access for enormous amount of data, including what kind of dosage of medicines has been given for each and every prescriptions for inpatient and also for the outpatients. So what kind of data privacy and regulations that we are looking forward to put on AI in healthcare sector? So it will be able to control that in a little bit.
So you've got a huge amount of data, and you want to know how that should be used to develop treatment algorithms?
We need some kind of regulations for that to have a data privacy. So is there any regulations that's already there in UK and US to follow?
There are huge data sets in both countries held in different repositories. For instance, the NHS has enormous data repositories. It does not perhaps access and use those data as quickly and intelligently as we would like. There are challenges getting access to the data to analyze the data. but there's a wealth of data there, and to get real-time outputs for patients according to how they are treated, according to their comorbidities, according to their social environment, their socioeconomic status, all of those things are potentially doable with the right collaborations. I think we do not have the workforce within the NHS to deliver that directly. So you might want to start approaching those people if you have systems that can give us intelligible outputs, and I'm sure they are available in other countries around the world as well.
Okay. I'll just make one other comment. I think, you know, applying an AI algorithm onto a population health data set can be remarkable. You can identify at-risk patients in a population. But again, the question is, what do you do with that data? How can you then establish outreach to those patients to actually make a change? And that's where the physician shortage comes in. That's where we perhaps need to investigate physician extenders, like nurse practitioners and physician's assistants, which is not currently a model that's very popular in the MENA region. But these are things to consider.
I guess all I would say is that if we take a load of data and we analyze it first, we get information. And if you spend an awful lot longer, you might get knowledge. I think the last step that's often missing is that you look at that and you end up with wisdom.
It looks like we have another question, but I think we're out of time. I defer to my Master of Ceremonies. We're popular.
Hi, I'll try to be quick. My name's Catherine. I'm here on behalf of my business, The Kinetic Blueprint. And I'm really fascinated at exactly what David just said, but potentially looking a little bit further back along the path of the human. And that's what I'm dealing with all the time, is by the time we get to 18, we're so conditioned by our schooling system. Being neurodivergent, school doesn't work for everyone. No one's ever addressed that. The disconnection from humans to their own bodies is what, in my opinion, is the biggest problem. So once we have data sets, AI, all this information that hopefully becomes wisdom and then knowledge, but that's a long shot in today's world, it really is. Why don't we start back with a child at school, teaching them how to be connected to their own body? Like, why is that not where we're looking? I'm spending my whole entire life teaching adults how to help their children know when something's off in their body, when they're having behaviors like addictive eating issues or TV binging or alcohol, heaven forbid. David, I've read a bit about you at a young age. So why, as a medical kind of focus here, are we not focusing on potentially going very early on in life, teaching us as human beings to know, connect, and have wisdom when it comes to our own body? Then we don't have to worry about extension of practitioners, nurse this, nurse that, because you, your own self, walk away knowing exactly when and where you actually do and don't need care. Most people are very confused and disconnected, and that's why they're leaning so heavily on systems like the NHS. I myself have just come from England, only been here a year. I feel that's where the problem is, and I'd like to hear everyone's thoughts on that disconnection.
It's a fantastic point. As an internal medicine physician, my introduction into a patient's life begins at age 18. And in many cases, that's too late. Mm-hmm. I wish I could have had a conversation with that patient earlier. And, you know, we have a pretty sharp distinction in medical training between pediatrics and adult medicine. I think that's part of the problem.
Yes.
There is less of an emphasis on family medicine these days. So the general practitioner, the doctor that saw your daughter, saw you delivered your baby, saw your grandma, those days are behind us, and we have hyper-specialized into these subspecialty silos where, you know, if I'm an ENT, I only, no disrespect to ENTs, but if I'm an ENT, that's all I care about. And if you're having depression, I don't want to hear about it. Talk about that with your primary care doctor. Or if someone's 17, legally, I can't render care to that patient because there are policies that prevent me from doing so in the States. So I think it's a fantastic point. We do need to start upstream, both with processes and with patients. And I think that there should be a greater emphasis from a medical education standpoint to pump out more graduates into family medicine, which really, family medicine doctors have a unique position where they can care for someone at day one of life to the end of their life.
So I totally agree. Education is everything apart from genetics. And we do need to engage earlier, and I think we ought to be teaching populations about what is important to their health. We see an obesity epidemic, pandemic at the moment. I think every English-speaking country in the world is more obese than any other country in the world. I know the UK is the most obese country in Europe. These things are important, and actually we do need to get health education into schools and think about that as fundamental part of how people learn, and not just about maths and English and whatever other language you might be teaching them. That, I think, is more fundamental as we go forwards, and what we think about being a human being might be in the future, because we might not all be going to work to be doctors and, you know, bankers or whatever. So
and I really hope that we might not all be going to school, not in the sense of how that sounds, but that there are different ways of educating our children that never make a person like you feel sidelined because they don't fit a box.
I love the question. Gosh, for me, we can't do enough to look after our children because they're the next generation. I mean, I'll briefly explain. You know, it wasn't that I became an alcoholic and an addict at 42 because I was a multimillionaire. It was because I was a child who didn't know how to cope with life. I'll give you an example. I would come home from work and say to my wife that I was stressed. Now, that was my BS word for being unable to explain that actually I was lonely, I was scared, I was impatient, intolerant, people were unkind to me, I didn't know how to deal with feeling overwhelmed. I didn't learn those things as a young boy. I started drinking at 11 and gambling at 7. And it was to do with my home environment, childhood trauma, but it was also, nobody sat me down and told me how to deal with, how do you make a friend? What do you do when you feel anxious? What do you do when you feel lonely? I didn't learn any of those things, and I'm not pointing the finger and blaming the teachers, it just didn't exist. And I'd love to see a wholesale change where actually I didn't need to learn technical drawing, I needed to learn how to be a human being.
100%, yeah. Thank you.
I totally agree on that. I guess recognition is very important, recognizing the issues.
Thank you very much, panelists. That was fantastic.
Thank you, everyone.